So, what about lung surgery itself? In that same group of patients, again, not quite as many of them had oncogene-driven disease. We just tried to see the benefit of surgery and whether it could be helpful for these patients. I'm going to show a figure on the next slide, and this is my preface, my warning. Please don't take a screenshot and take this out of context. There are two survival curves that are superimposed on the same figure, but they are not equal groups of patients. And I hope that this is at least a little bit of a lesson on how we can interpret data in studies and how it applies to real life and to real patients. So here you see that we looked in our experience at patients who had a surgery or radiation across that 18-year period with oligometastatic disease. And the treatment was relatively safe in both groups. And over a period of follow-up of almost 5 years, the median overall survival after surgery in this group of patients was 55 months. The median overall survival after radiation in this group of patients was 23.4 months. It's super important that we don't try to act as though those two groups of patients were the same. And so that does not mean that any given patient would do better with surgery or with radiation. It does reflect the reality that we selected the healthiest, strongest patients with what we already thought were pretty good prognoses to have surgery. That doesn't mean that surgery is better or equal or worse. It means that we haven't compared it. This is not an appropriate comparison, and so you can't say one is better than the other in this specific study. But what you can say is that both of these strategies showed median survival time that was much better than what we had seen in patients who weren't getting any type of local therapy. And so both are reasonable treatments to include in clinical trials and patient care going forward. So how much lung should be removed if we do operations for this? This is something we surgeons debate a lot, and people may have heard of operations like a lobectomy or a pneumonectomy, wedge resection. And there is really an abundance of data, lots of clinical trials where we discuss and debate over and over how much lung we should remove for early stage lung cancer, for stage 1. Stage 2 and stage 3, it's pretty well accepted that we will typically take out an entire lobe or more if we need to, but we don't go less than a lobe. But interestingly, we found that for patients who already have stage 4 disease, taking out less than a lobe is actually the same as taking out a lobe as far as we can tell, as long as we get all of the tumor out. Because ultimately, when you take out an entire lobe, even if that's more than what might be needed for early stage disease, the goal is to keep it from spreading elsewhere. Once it's already spread elsewhere, it may not be of benefit to take out an excessive amount of lung. And this is something that we were able to show again with a larger group of patients using some international patients as well. So how should we handle the lymph nodes? In general, most surgeons, if they're doing a good operation, are going to take out a lot of lymph nodes to be able to see the structures in order to get thorough information from the slides from the pathologist. But how many do we really need to take out? We do know that in early stage disease, in stage 1, it matters how many nodes you take out in terms of the patient's survival. But we've actually found that in stage 4 disease, taking out as many as possible to provide good prognostic information, to get information to our pathologists and our colleagues in medical oncology is helpful in making treatment decisions, but it doesn't directly change survival. So ultimately in these operations, the number of lymph nodes taken out, we don't know that there's a right answer, but probably the right answer is to take out as many as you can as long as it's safe and not to do anything that is too dangerous or heroic because it may not change the outcome. In terms of looking at long-time outcomes of using surgery for local therapy in these types of cases, we have some pretty good data. And what I want to point out when you look at this slide is this is how we're used to looking at the proportion of patients surviving or the proportion of patients without progression. We have progression-free survival here in the red colors and overall survival in the blue. And the numbers that you see at the bottom across the time are in months. This is how we normally think about patients with stage 4 lung cancer. We've got 0, 12, 24. This is how we often think about it. And a lot of our figures going back a couple decades, we never really got much higher than about 12 or 18 months. Well, as much as I love this figure and seeing how well patients are doing with local therapy, I like it even better like this when we show it in years. And that's an exciting change to be looking at patients with stage 4 lung cancer getting local therapy and seeing these progression-free and overall survival numbers that are up in years. Because that's what we want is prolonged, meaningful lives for the patients for whom we care. And, you know, we've had an opportunity to combine some of our results with those from colleagues across the globe. And ultimately, when we look at these bigger data sets, we get more patients that we can put together. And we're really seeing these phenomenal longer-term outcomes from offering surgery as part of stage 4 disease. And so this is what we're looking at is, you know, median overall survival extending out 78 months, median progression-free survival more than 3 years. So that's very exciting. So beyond the survival, why do we operate? The rationale for local therapy, whether it's surgery or radiation, is theoretically to get rid of the primary source of new metastases, to decrease the number of tumor cells that can develop mechanisms of resistance, to debulk so there's lesser disease burden for effective drugs, and to maybe convert what was once a lethal disease to a chronic disease, even if it's not no evidence of disease. Some practical reasons for surgery itself is that we can obtain tissue for looking at pathologic response. So what can we see under the microscope? What can we do with mutational analysis? We actually just saw a study at the North American Cancer Congress on Lung Cancer in Chicago last weekend, where the group from UC Irvine showed some data demonstrating a very small series of, I think, 6 patients. For all 6 of those patients, the information they got looking at under the microscope showed that they changed the systemic therapy, the drug therapy for the patients based on having that information look at under a microscope. So that's all super important. It allows us to address any residual cells that might theoretically be left after radiation, because we don't always know when we look at imaging after radiation or after drug therapy if those cells are alive. We don't know until we take something out and look at it under a microscope. For some patients, quality of life is better with surgery. For some patients, it won't be. And that's a big part of understanding an individual's health, psychological, social situation, and really making sure we tailor every patient's treatment to that individual specifically. And for some people, it's just that closure of answering unknowns, which if it's a reasonable safety profile, reasonable risk, that can be a good reason in and of itself. So what does this mean for you as a patient? There's no single right treatment for everyone. Treatment plans should consider the number and location of the cancer spots, the response to medications, your overall health, and as well as your goals and preferences. And it needs to be guided by a multidisciplinary team. So when we think about where these things all fit together, for local therapy in stage 4 disease, again, we're trying to minimize the number of tumor cells that can develop resistance. We're trying to prolong the efficacy of a drug as long as possible. When we look specifically at surgery, we can get all this additional information by looking at it under a microscope. And when we look at oligometastatic disease, again, so patients with really just a few number of spots, the goal is really to get rid of all disease possible, because we often are able to do so. So we need to understand that polymetastatic is not the same thing as oligometastatic. But I will get into that a little bit with my last couple of minutes here. So if we are going to operate, who should have surgery and what's the best way to do it? We do have some guidelines that we published in 2025 through the Society of Thoracic Surgeons. And this is a busy table that goes through the guideline recommendations, but I want to provide you with a quick summary of what these guidelines are, which is that the data provided strong recommendations to consider lung surgery as part of local therapy in oligometastatic disease, and that all patients with oligometastatic disease should have multidisciplinary evaluation. There were moderate recommendations for lung surgery in some people who have more than 3 sites and some people who are progressing in a small number of spots. But there is not adequate evidence right now to tell us how much lung we should remove, how many lymph nodes we should remove, or really whether it's better to do it minimally invasively or a little bit more invasively. Really, those things should be left at the safety discretion of the surgical team. The most important take-home point, though, from these guidelines is that all patients with oligometastatic lung cancer should undergo multidisciplinary evaluation, including surgical consultation, even if that means that the surgeon explains to the individual why they might not be a surgical candidate. I personally believe that every patient deserves that opportunity to have that discussion and to understand what the nuances are about their specific case and why certain treatments might or might not apply to him or her.